Good morning, everyone. First of all, I would like to thank Laura for the introduction. I was given the topic to talk about the pharmacy home care services in psychiatry, and I will share some of my experience when I do home visit in Hospital Sentosa. This is the outline for my presentation. First of all, I will talk about the home care pharmacy services in psychiatry and why we have to start the home visit services. And along with my presentation, I will share some of the experience. What are the challenges that I met during the home visit, and one short case study. Home care pharmacy services, or formerly known as HMR, Home Medication Review, is one of the pharmaceutical care services that was implemented to ensure the continuity of patients' care after they return from the health facilities. This is the protocol that we use for our home care pharmacy services. It is published in 2019 and is now second edition. This protocol is available for download at pharmacy.gov.my. The home care services in Malaysia now is mainly focused on patients with special needs. For example, like psychiatric patients, geriatric, and stroke patients. But we see that in future it may focus on some of other illnesses with multiple medications. Now we'll talk about the home care services in psychiatry. Why we have to start the home services? Several studies show that there are more than 50% of people with psychotic disorder are not adherent with their medication, and the risk of relapse had increased 3 to 5 folds once the patient stopped the antipsychotic medication. The major psychiatric disorder, they have an impact on the adherence because it affects on their reasoning skills. A study done by Mibel in 2013, it shows that the low rates of adherence, especially due to the schizophrenia and bipolar disorder, can cause exacerbations of patients' illness, and this subsequently lead to rehospitalizations, relapse of symptoms, and reduce the efficacy, the effectiveness of the subsequent treatment. And it also leads to wastage of limited healthcare resources. This is a study done by a previous HMR pharmacist in Hospital Bahagia. This study showed that there is a significant improvement in patients' medication adherence up to 6 months of HMR follow-up, as shown by pill counts and the MAS score. It also shows improvement in the patient's knowledge towards their medication and subsequently improve their quality of life in terms of family component. CPU is offered in all major and district hospitals, but not all of them have a CPU pharmacist. Now I will talk a little bit background on our hospital-based Community Psychiatry Unit, HCPU Hospital Sentosa. We started off at 15 August of 1990, and by that time it was known as Community Mental Health Center. Subsequently, we renamed to Hospital-based Community Psychiatric Nursing Unit in 2017. Pharmacists only joined in the team in 2010. There are many objectives of why we have to do a home visit in psychiatry or in some chronic illnesses. The main objective of home visit is to emphasize the quality use of medicines in the home or the residential setting. This can be done through many ways. Pharmacists can educate the patients or the caregivers on the proper management of their medication supply, and this will lead to improve their patients' understanding and we hope that we can improve their adherence to the treatment. First of all, we can do reconcile the patient's medication. We have to ask the patients or the caregiver, what are all your medication? Identify the medication they are collected from the clinic, from the hospital, and then if there any OTC or supplements they purchase outside. We also have a role to identify and manage the possible medication-related issues. For instance, we have to detect is there any drug-drug interaction, is there any ADR, and then is there any other possible issues that if they take too many pills. Is there a burden to the patients, pill burden? We also hope to create awareness and to reduce stigma in the community. Besides that, we also need to identify other psycho-social economic issues. For example, if the patients of our care, they are jobless, is there anything that we can do? We can refer to our OT for job training, for job placement, and then are they receiving any welfare, bantuan? All this, we hope to reduce the relapse and hospital admissions, and this subsequently can improve the patient's quality of life. This is the organization chart for our CPU. Our head of department is the director of our mental hospital, and we have a specialist in charge for our unit. Our specialist in charge is Dr. Sharifah. I believe most of you met her during the presentation yesterday. After that, we have medical officers, we have nurses, we have medical assistants. But remember, CPU is made out of multidisciplinary team. We are aimed to provide treatment and rehabilitations to persons with mental disorder. With this, we also work along with other disciplines. We work with occupation therapists, physiotherapists, counselor, clinical psychologists, medical social workers, pharmacies. Has CPU team structure and setup. Our staff consists of doctors, nurses, medical assistants, pharmacists, and driver. This is the team that we travel along when we do home visit. We plan to visit, our hospital, our CPU team visit patients every day. Our visits start around 8:30 in the morning or after meetings. The total number of patients that we visited per day is, this is just an estimation, it's around 7 to 15 patients, and it depends on how many teams we go out every day. Usually, there are 2 teams. For most patients, we will visit them weekly, 2 weekly, 4 weekly, 6 weekly, and 8 weekly. The services that we provide are acute care, executive care, and psychogeriatric community. For acute care referral, this referral, they are aimed to refer to CPU to provide the intensive support for patients with mental health crisis in their own home. It could be a referral from our outpatient or from the ward. Usually these cases, they require close monitoring and the patient are in crisis. For example, some of them may experience early relapse symptoms after they discharge from the ward. In this case, we will visit the patient every alternate day or weekly or even 1 to 3 times per week until the crisis resolves. CPU usually will pre-meeting with our psychiatrist. We have to decide a plan first for this patient. If let's say when we visit the patient and then the patient is suddenly aggressive, what can we do? What can the team do? Another services is assertive care. This assertive care is usually cater for our commonly CPU patients. They are mostly referred to us due to few reasons. Most of them is a logistic issue. They couldn't come to our OPD for follow-up or for depot, and some of them are stay very far from clinic. And these patients, they are usually are not stable enough for us to discharge them to the nearest facilities. Some of the patients are frequent relapse or frequent defaulter. That's why we have to monitor, and then we have to home visit the patients 2 weekly or 4 weekly. We may see some of the patients in their house or wherever that is most appropriate or convenient for them. We do see our patients at the coffee shop or the restaurant. That is the place that they are walking. And then some of the patients, we even met them by the roadside because they have a wandering behavior. Sometimes we have to chase along, we have to travel through the route, and then to see, and then we have to visit the coffee shop and then ask the owner, do you see this patient come here, and then do you see this and this wandering around? For psychogeriatric, the psychogeriatric care team had only been set up since 2019. This psychogeriatric team, they consist of one specialist, a medical officer, and one staff nurse. They will visit the patient once a week, every Wednesday. They will do some assessment and activities at the patient's house. These patients, they still come to Hospital Sentosa for follow-up. However, during the clinic review, this is an example. One of the patients, they noticed that the patient had a frequent fall. So the team decided to pay a home visit for the home safety assessment. After they do the assessment, if they found that there is a need for home safety modification, they will refer to our OT for to do some signage, to put a color coding, like how and educate the patients, or the most importantly is the caregiver, how to take care of the patients. If let's say there is the patient had fall, and then they have to assess whether the staircase, and then maybe you can ask the patient to move and stay in the room below. In other cases, they also refer to physiotherapists, dietitians, social workers, or pharmacists if they're needed for the advice or the counselings. This is the Hospital Sentosa area of coverage. There are boundaries between our CPU SGH and Hospital Sentosa. For Hospital Sentosa, we actually cover 5 zones. Zone A, B, C, D, E. Our area can cover up to Seren, Siburan, until 28 Mile, and then we even go to Lunduk, Bau area to visit our patient. And Samarahan is still under our coverage. There are 2 case managers per zone, 1 staff nurse and 1 medical assistant. These 2 persons are BVIP because they are responsible for the care of their patient. They usually know all the patients under their care, from their medications up to the social issues, whether the patient have any compliance issue. We can always refer to case managers because they know the most for their patients. This is the CPU statistic. The numbers of patients for CPU had dropped drastically since 2015 because there is a redistribution of patients to the nearest CPU, which is our CPU Hospital Seren and SGH. And some of the stable patients, we already discharged to our OPD or to the nearest Klinik Kesihatan. So until 2021, there is still roughly 246 of CPU patients under care. Now, I would like to talk the role of pharmacists. Pharmacies play a major role in CPU. Maintaining a good relationship with the patient or caregiver is a key element in home visit. We have to build rapport, and then we have to maintain the relationship. In this case, the case manager, they play a big role. They have the phone number, and then the patient, they can contact the case manager anytime. I saw one of my case manager, she received call even at night just to hear the patients. If we need to, we have to know more about the patient, then we have to ask the case manager first. During the visit, we have to be respectful, and then we have to be friendly and introduce ourselves to the patients. That's one of the way that we have to build the rapport first, because if the patient didn't know you, they won't tell you more about their problems. We do have to assess the side effects of the medications, and at some time we have to give psychoeducations, and we do have to check their medication compliance. Most of the patients, they are more comfortable or relaxed at their familiar environment, which is at their home. Thus, they are more inclined to answer the questions. What the patient doesn't tell you, you can try to infer from observing the home environment, the medication storage conditions. In cases the doctor didn't follow the home visit, pharmacists can do the mental state examinations, and we will do some interview session too. This I will explain later in the next few slides. These are some of the preparation works that we have to do before home visit. First of all, we have I will receive a jadual lawatan from the CPU unit. In the jadual lawatan, I have to check whether the prescription is still valid or is there any expired prescription. For expired prescription, I have to remind the case manager to get the doctor to prescribe a new one. After that, we will prepare and packing the medicines. We do have pre-visit meetings 3 times per week for case discussion. Either it's before we plan for visit or after we visit, then we have to do some interventions. During the visit, as I mentioned before, we have to introduce ourselves, we have to build a rapport. After that, we can try to assess their compliance by asking them, how do you store your medication? Do you have any side effects? Do you experience like tremors, EPS symptoms? Before we dispense the medications. These are some of the compliance aids that we can use. One of them is the medication chart. This is a simplified medication chart that we try to include all the medication that the patient is taking, the antipsychotic, and then like others antihypertensive, and then we give simple instruction to this patient. We write that this one you take once a day, and then either morning or at night, and then what are the indications for these patients, and then before or after meal. We also do Pillbox Training. We encourage the patient to involve in their medications. They have to know what type of medication, how many tablets, and this medication whether they have to take in the morning or at night. We can use labels, colors, or pictures to assist the patient to recognize that, because some of the patients, they really didn't know how to take. Even with the clearly envelope, ambil satu biji 2 kali sehari, the patient doesn't know because they can't read. That's why Pillbox is quite important, Pillbox Training. This is another record pengambilan ubat. We can do a simplified one, and then we write down the dates, and then we remind the patient to tick or sign each time after they're taking the medicines. This can reduce the risk of double dosings. Sometimes we do ask the patient to, you can use the alarm clock in your handphone just to remind you to take the medicines. After visit, there are some documentations that we have to do. We have to enter the counseling in the PHIS. For HCPS 5 form, this is the summary of activities during home visit. This is a report form. It covers the interventions and then the request that was done during the home visit. We also need to fill the information gathering form and for first visit and subsequent session. All this you can find in the protocol. Any interventions or counseling must be documented in the case note and discussed with the team. Now I move on to a case study. My patient, 48 years old female. She is diagnosed with bipolar disorder. She's a known case of frequent defaulter. Her BP is normal. We have to take note the random blood glucose is 18.7 millimole per liter. Her current medication is aripiprazole 20 mg once a day, Epilin Chrono at night, and injection clopixol 200 monthly. Her chief complaint is she claimed that she is very tired, no strength to do house chores. Otherwise, she is maintaining well. The mood is stable. For the mental state examination, it's a structured way for us to give a description on the patient's current mental state. We have to assess their appearance and then the eye contact, and then whether they have the mood is stable, and then their speech. We have to cover a lot for the mental state examination. I will just cut it short. For this patient, is a good eye contact, the mood is stable, and she can communicate effectively. Let's say during the review, we have to ask the patient, do you experience any delusions, any hallucinations? The hallucination can be audio hallucination, they are hearing voices. If the patient, they tell us they are hearing voices, then we have to ask more. Whether it's female voices, and then can you able to ignore it, and then how frequent the voices come, and then any visual hallucinations. And then one of the key questions that we can ask is, do you feel anyone want to harm you? Are you feel comfortable with your medicines? Are you feel safe now? That is a few of the key questions that we can ask during the review. During the review, also we have to assess for any EPS symptoms like tremors, and then the tongue tremors, and then any body stiffness, and then rigidity. We do have to ask the patient about their sleep, because poor sleep you can lead to poor sleep, and then no appetite. That actually implies of they have other issues beside of the medicines. And then this we have to ask more. For compliance assessment, for this patient, the husband claimed he supervised her medication daily. Beside all the 3 medications that I mentioned before, this patient also on glucophage 750 BD dosing, but she only took OD dosing. This is a chart that we can use to identify some of the possible drug-related problems. We can check whether the drug of choice is good, and then the dosing wise is too high or too low. And then this is a chart that I mainly use to detect any PCI for my patients. Now for this case study, one of the issues that I noticed is the random blood sugar. It's 18 point something. The HbA1c is 11%, and then the fasting blood glucose latest is 11.7. She complained of body weakness, drowsy, and headaches. It could be a symptoms of hyperglycemia. This is our plan. We have to emphasize the importance of compliance and counsel the patients on the complications of diabetes. For this case, probably insulin or other combination therapy would be beneficial for this patient. I'm not an expert in diabetes, but for this case, I will just refer to or remind the patient to go follow up to see their doctors, or go to the nearest clinic for the diabetes management because they know more. We also can refer our dietitian for diet education and advice on the lifestyle modifications. Now, we come to an issue that can we use clopixol for this patient? Clopixol is only indicated for treatment of agitated or violent patients. According to formulary, it's indicated for schizophrenia and other psychosis. Just now, this case study, this patient is diagnosed with bipolar. Now, can we justify to use the clopixol injection for these patients? Because this patient initially she presented with some psychotic symptoms. Thus, she was started with injection clopixol. But all this while she's maintaining well, and then with the injection clopixol, and then even with combination with aripiprazole, and she complained of no side effects. So our plan is to suggest the doctor to review the patient's treatment, and meanwhile we have to train the patient to adhere to oral medicines and explain them about the importance of adherence. When the compliance is not an issue, we can IV to off the clopixol since clopixol is not indicated. Aripiprazole is a magic drug. It's effective as monotherapy in mania or as an add-on agent. For this patient, because she has a diabetes issue, aripiprazole has a minimal risk on the glucose tolerance. So according to CPG, aripiprazole in combination with valproate can delay the manic relapse. So among those antipsychotics approved for use in bipolar, aripiprazole is suitable for this patient. The TDM level had never been carried out since the referral to CPU. So our recommendation is to fix a date, to ask the patient fasting, and we can do a blood investigation, and then we have to check the TDM for this patient, TDM epilepsy. This is one of the ways that we have to we can check their compliance. Okay, now I move on to expectations. I think most of us, we expect when we do home visit, we come to a clean, tidy house, and then the patient will sit quietly for your interview. But this is not true for most of the cases. Okay. There are some pictures of the reality. We have to visit to our patients that have many issues, a poorly maintained house, and then some of the patients, their house, maybe the ceiling of the house having collapsed, then we have to refer to OT for some modification, and then we have to ask some of the NGO to help us. These are some of the pictures that we see in our patients. Okay. We do face some transportation issues. We have to use the boat, and then we face the flood issues, and then the car breakdown, and then even car accident. For this one is sometimes we have to send our patient to hospital because they don't have any transport. We have to call along the police officer, and then we met the patient at the roadside to give them the injection. Okay, now I move on to some of the challenges and risks. First of all is the changes in weather. It can be a bright sunshine in the morning, and maybe 1 or 2 hours it suddenly rain cats and dogs. And then we do face like transportation issue. We don't have transport, that we have to use our own transport, but now we can't do that. We have a SG for us to do home visit, and then can you imagine 5 of us sit inside a small console along with the specialists, the nurses, the medical assistant, and the driver. We travel to patient's house, and guess what? The car suddenly breaks down, and then we have to wait by the roadside for another team to come to carry us, and then we have to continue our home visit. This is one of the challenges. Okay, we do face physical hazards like dogs, animals, some of the patients, they will use like dogs to scare us away lah. They don't want us to visit them, and then they will just let go of their dogs. And then one of our previous HMR pharmacy, she actually almost got bitten by the dogs because of during home visit lah. Okay. This is the logistic and accessibility issues. We have to walk across those bushes to just to go and see this patient. He stays somewhere in, we can call it a forest. It would take like maybe 5 to 10 minutes of walking from the main road just to enter their house. Okay. Some of our patients have socio-economic issues. This is one of the houses that we visited lah. We can see from the picture is poorly maintained. The ceiling probably will collapse soon. In fact, some of the walls at the behind of this house had collapsed, so they just used the papan just to stick it, and then we have to do a lot lah for these patients. Okay. This is one patient that I visited last week. Okay, I will just say share some of his story lah. He's a 66 years old male, single. Okay, this patient stay in a house. There is no electricity and no water supply. The water, he just used the rainwater. He just collect like that. Okay. When we visit him, it's a minimal speech lah. The patient doesn't talk more, and then we can't even assess for their symptoms because the patient don't want to answer anything. Everything we ask is he just nod her head or just shake his head. Okay. In terms of medication, this patient is on risperidone and benhexol. Okay, this patient has a skin problem as well. He refused to take the medicines. Okay, so the medicine we have to prepare and then send to his nephew, and then his nephew will pass the medicine to the coffee shop owner. The coffee shop owner will instruct his staff to put the risperidone drop inside the food and drinks because this patient will go to collect the pet food every day. The nephew still gives some pocket money to the patients. So far, I would say like family support is quite good because the nephew is willing to help us to send the medicines to the coffee shop and instruct them, and our case manager even have to pay a visit to the coffee shop to see how the staff they actually put the medicine, despite the medicine inside the food and drinks for these patients. There are few reasons that why patient will this patient is he actually refused for depot injection. So we just he is a very EPS prone. If we slightly increase the risperidone drop a little bit, the patient experience EPS like body rigidity, because at one point of time the patient couldn't come out from his house when our case manager visited him. They keep calling the patient, and then the patient said, I can't move. He just stayed there. He just lie on the floor. It's very rigid, and then we have to give the Camadrin for this patient to relieve the EPS. After that, we have to carry out investigation. How come the patient suddenly have EPS? So they visit the staff in the coffee shop, and then they say, the staff says sometimes they drop up to 2 meals. Actually, it's quite a lot lah, because his dose is only 1 mg per day. CPU also involved in other community projects. We have bedside teaching. The topic is about good touch and bad touch at Camp Desa Bina Diri. In this center, we noticed there are lots of complaints on inappropriate sexual behavior. So we have to educate the occupants on this topic. And then we also distribute rations to our patients. We receive the food rations from the NGO like Hope Place and then Yunnan San Tang. They will deliver to us, and then we have to identify the patients, because most of our CPU patients, they have financial issues. Okay. Besides this, we also carry out mental health talk at polyclinic. We do some screening for them. During the COVID vaccinations, I would say our CPU team had done a very good job. They had managed to administer the vaccination to almost 99.9% to our CPU patients, with only 1 or 2 patients that refused for vaccinations. This is regardless of the route and then how far they stay, because some of them that stay in Bau, the Lundu area, we have to arrange our schedule in our busy schedule to give a vaccination to them, and then they even have to work during the weekend. This is the national guidelines for new norm in psychiatry and mental health services. I think all of you can go and download this. It's actually tell us how do we have to deal, especially in this COVID endemic now. Okay. We have to categorize the patients according to the needs to 3 categories. For the patient with high risk of relapse and then on depot, we have to face them regardless of what. For those patients who are quite stable, we can do telephone consultations, and then we can ask the patient to stay at home, and then we just drop off the medication, and that one we wouldn't stay at their house for more than 15 minutes. This is the SOP for home visits. Usually before the home visit, our case manager will call the patient to ask them, we will plan to visit you on which day, are you available, and then if you have any other follow-up on that specific day, we have to reschedule the home visit. And then during home visit, we are strictly have to wear a mask, face shields, and then strict SOP. Okay, now I would like to ask any question from the floor.
See the chat. There's nothing in the chat.
Okay. Never mind. I will just continue. We do have some questions lah. Many people will ask, how many times do I have to see our patients? Well, it depends on the patient needs and schedule. At least 1 follow-up visit is essential. For those patients that are quite stable and then all the PCI have been resolved, we can plan for discharge to the nearest clinic. Do I have to fill every form at every visit? No. Before we go for the visit, we have to have a clear idea of what we plan to do. For example, during last visit, you can encounter this patient. They have still have lots of pill left. For example, the patient doesn't want to take this because of complaint of sleepiness in the daytime, and it affects the patient's work. We can do an intervention on the next visit. We can tell the patient, we will reduce your dose slightly at night, and then maybe you can change this medicine you can take in the morning. I would say most of us, we have to commit to HMR to some extent, that we have to see the patients. For me, is I didn't see my patients, I didn't follow the home visit every day. I try to at least follow their visit at least 3 times per week, because at the same time I have to cover for OPD services, I have to cover for my MTAC. So what are the manpower requirements for running a HMR service? We require a minimum of pharmacies, and then because HMR psychiatry is depend heavily on building rapport and trust, we do not encourage rotating team. Okay. My take-home message. One of the questions that I received is, do pharmacists work overtime most of the time? Actually, no. Our visit we usually start at 8:30 or 9 a.m. after the pre-visit. It will roughly take half day. The latest that I will reach office is around 2. but there's in some circumstances that I have to reach pharmacies by 3 or 3 something lah. Especially the trip to Samarahan area, Southern Jaya is quite far lah. Okay. Oh, okay. For patients that we see in CPU, usually they have poor insight, stigma, logistic issue, and then poor family support. So my take-home message is, HCPU is not only home visit and deliver medications. It usually involves more because we are a multidisciplinary team, and then mental illness does not discriminate. It can affect anyone regardless of your age, gender, geography, your income, your social status. So I would say pharmacist's role in CPU is quite important because we are expert in medications. We can educate the patient, we can empower the patients or caregiver with the knowledge. But we have to work along with other team members too, because they are just important as us. With this, I end my presentation today.
Got questions. Okay. Safe to go visit acute patient safety-wise.
Okay, I received one question. Is it safe to go visit to acute patients? Usually before the visit, we'll try to because they will have a pre-visit meeting to discuss the acute referral case. And then during the meeting, they will usually ask the issue, is it relapsing? And then one of the acute referral that we received recently is the patient experienced early relapse for her schizophrenia because of the Chinese New Year, and then the patient suddenly stressed because of her son throw away her clothes. But in this case, the patient doesn't have any aggressive behavior. So I would say for this patient, for this acute referral, is still quite safe for us to go and visit them. In fact, I went there and then I talked to the husband, how do you serve the medications, and then is there any problems, and then while we separate the patient with the husband, the doctor will review on the patients, and then I will review the husband on her medications. Another question is, how do we keep social distancing in the car? During the COVID, the MCO, we actually only have 4 person limited to visit lah. So during the MCO, I will just follow some of the trips. But now, since COVID is like everywhere, anyone can get it, so we just go and then we just wear a 3-ply mask, and then we have to wear our face shields, and then we try not to openly your mask and then to drink inside the car, and then we try to avoid having lunch at outside together with the team.
What is your most
Okay.
Can you expand how? Have you encountered any?
Okay, one of the question is, have you encountered any patient using COVID as an excuse to reject the visit? In fact, we have patients. The patient refused to come out to meet us. Usually during this period of time, we usually meet the patients outside of the house at the car porch area. They will set out a table, and then they will ask the patient to come out. I think for the past 3 months, the patient refused to come out, and then the family member just show us the CCTV footage to show us. Inside the CCTV, we just have to, we can only see the patient is self-mumbling, etc. But for other information, we have to ask the caregiver whether the patient does have aggressive behaviors or not. After discussion with our specialist, we actually would like to advise the caregiver, since the patient is already refused us for the home visit, We plan to visit the patient probably 2 months once, and then the medication will supply monthly. The option one is the CPU team will send the medicine to the house. Another option is we'll ask the caregiver to drive through at our pharmacy to collect the medicine only. Some of the patients, if they refuse visiting, do we still have to visit the patient even they do not agree to it? For these questions is, I would think that we still visit the patients. We have to ask them why you refuse visiting, because maybe they have a stigma to us. They are worried that we want to catch them and then we will have to put them in admissions, because they don't understand. They don't understand. With CPU team, we do more on psycho education. We have to tell them we are visiting you and then we provide you medicines. And we have to ask the patient, do they have any caregiver? Sometimes the patient might refuse to see us, but the caregiver insists want the CPU team to visit the patient and give the medicines. For our Hospital Sentosa, we do not, for pharmacy side, we do not get consent to for the visit, but the case manager, all of them, they get the patient's consent before the home visit.
Pharmacy only team 需要 consent， 如果是 multidisciplinary 不需要。
If a multidisciplinary team, we don't need the patient's consent. If only pharmacy home care services visit home pharmacy team alone, then you need to get the patient's consent. Okay. Is there other ways to convince the patient to take the medicine apart from telling that the medicine is a vitamin or for blood pressures? One of them is it's not an easy task to convince the patients. It actually take lots of times to give the psycho education. I believe psycho education doesn't work for the first time. You have to continue do it every visit. We have to tell the patient this medication can reduce your disturbances, can improve your quality of life. And then after that, we have to identify, is there any other issues that why the patient doesn't want to take the medicines? And then is it probably due to the side effect? If side effect, then we can always try and then or cut down of the medicine dosage, and then or even try a new medicines. We have some patients that refuse to take the medicines, and we have to ask the caregiver to spike the medicines inside the food and drinks. For the pre-packing of the medicines, it will say I will just prepare the medicine just like the OPD prescription. If let's say the jadwal rawatan that I receive is we have to supply 6 weeks, then or 29 days, I will do the transaction in PHIS and then prepare the medicine and pack in a plastic bag. And then during visit we just drop off the medicines, but at the same time we do check the pill counts at the patient's house.
Last question.
One last question is how do we convince patient on tapering dose or off the medication? Okay, some of the medicines like clonazepam, benzodiazepine, and benhexol, we usually tell the patients that if let's say you don't have any poor sleep, and then you feel like you can stop the medicines, you can stop it, taper it slowly. For instance, one of our patients is clonazepam 1 mg, but the husband, this is the acute referral that I mentioned just now. Our doctor prescribed 1 mg ON, but the husband is hesitant. He doesn't want the patient to be sleepy. So he said, can I try on 0.5 first? I said, yes, you can try on 0.5 first. And then when we visit the patient after 1 week, And then we found that they still left like 5 tablets of the clonazepam. So we asked the husband, and the husband said because the patient now can sleep at night and then doesn't wake up frequently in the midnight, and then daytime also okay, and then seems like the crisis have been resolved. So for now, these patients we revert to assertive care, and then the patient is on clonazepam PRN basis only. We educate them lah. For benazole is if let's say the patient doesn't have any side effect like rigidity, uprolling of eyeball, tremors, you can take it on PRN basis. It's not only during home visit we emphasize that. We also emphasize that in our outpatient dispensing. We tell the patient, we always ask them, do you have any EPS symptoms like rigidity, you cannot, tremors, and then do you feel comfortable if you take this clonazepam on PRN basis? Maybe you can try on EOD first and then slowly taper it to when necessary only. Psychoeducation is very important. One of the patients that I see is very successful in psychoeducation, and it takes like more than 7 years. When I first met the patient, he was just inside the locked section, and then the caregiver, they just serve the food like how you serve your pets. They just put it on the floor, and then the patient don't have any mattress, and then the patient just pee all over you inside the locked section. And then shower? No, the patient didn't shower. Maybe once a week. Even shower also, they use the water just like that, and then the water is tap water instead of a boiled water. So in this case is we have to continuously give psychoeducation to the caregiver. So every time home visit, we actually ask the patient, can you please let the patient to come out? 5 minutes or 10 minutes is enough to spend the interview time with us, with the CPU time. So I think our case manager, our CPU team had done a very good job, because after that I see the patient can come to our OPD and they actually discharge this case to our OPD. When the patient come to our visit, I ask him, are you feeling okay? He said yes. My family member now, they are letting me to come out from the house, and then they let me join them for dinner. That's why I think psychoeducation is very important, and it takes many efforts, and it takes times for us to establish the rapport, and then we have to reduce the stigma from for the patients. Ask them not to scare, because mental illness is just like other illness. It's just like diabetes. If you are on your medication and you are compliant, you can do anything. You can start walking. Okay, you can live a normal life just like others. With this, I will just end my presentation. I thank you for everyone's feedback, and then all the questions, and I hope everyone will benefit from this presentation. Thank you.